Hi everyone, I'm Jana Goldberg. I'm going to be speaking about telemedicine and cardiovascular practice. First, a few notes about CVI Heartbites. CVI Heartbites is a free, non-accredited educational program produced by the Cardiovascular Institute of Philadelphia, featuring succinct presentations delivered by leading experts on timely topics in cardiovascular medicine. This CVI Heartbites segment focuses on cardiovascular disease in the age of COVID, telemedicine in cardiovascular practice. Please note, this presentation was recorded on April 21st, 2020, and the information was up to date as of that time. At the end of my presentation, you'll see some additional resources and have the opportunity to contact me with any questions you may have. I'll give you a brief background on myself. My name is Jana Goldberg. I did my training up in Boston at Tufts prior to entering into cardiovascular fellowship at the Hospital of the University of Pennsylvania. Served for several years on faculty at both the Hospital of UPenn and the Philadelphia VA Medical Center. And I also had a niche in sports and exercise cardiology. After this, I moved on to be medical director of Heartbeat Health, which I'll tell you a little bit more about later. A brief disclosure. I work for Heartbeat Health, which is a virtual cardiovascular care company. I'll briefly mention again at the end of this presentation, but today I'm going to talk about the broad topic of telemedicine and cardiovascular practice. And I'll outline what we'll talk about today. First is the current state of telemedicine as it relates to the pandemic. Second, we'll define telemedicine. We'll talk about the 4 pillars of virtual care, telemedicine and cardiology. We'll talk about some practical points, and then I'll come back to our virtual cardiovascular care model at the end. But first, telemedicine is having a moment, which is why I'm here right now. It's been slowly ramping up for several years, but there's been this tectonic shift in medicine in response to COVID-19 mitigation efforts. And there really have been few other examples in medical history of which years of progress have been made within just a matter of weeks. And whether you're from a private or an academic institution and ready for this, COVID has left few other choices for viable care, particularly for those with chronic medical conditions. These are a couple charts from Heather Fernandez at Solve Health, and what they highlight nicely is when you look at the percentage on the y-axis and time on the x-axis. On the left, you're looking in blue at in-person face-to-face visits, and in pink, you're looking at percent of telemedicine visits. And what you see quite nicely is that there's been a rapid decline in the face-to-face visits, and they've really been replaced with those telemedicine visits. In fact, there's been over a 3,000% increase in telemedicine video visits since March 5th alone. Pick up the phone, pick up the newspaper, and the media has really been covering the role of telemedicine in response to COVID, such that now it's a household term. Patients are inquiring about their access to physicians without having to leave the home in compliance with their stay-at-home orders. So we'll briefly define telemedicine. Telemedicine's been around for at least 50 years. Some would argue in other means as far back as about 100 years. And interestingly, this was inventor Hugo Gernsback's depiction of what telemedicine is in about 1925. What he envisioned was that there was a doctor with these robot video game-like controllers who could then remotely evaluate and diagnose a patient. And really this isn't necessarily, actually it's not what telemedicine is these days. Really what telemedicine is nothing more than a phone call or a video call, communication between a patient and a provider. But telemedicine is really just the beginning. Using the common tip of the iceberg analogy, it's really just that tip of the iceberg, and what's below the surface is really what I'm excited to be part of what's coming next, which is overall digital health landscape. And digital health is really composed of 3 things. That's data, remote patient monitoring, and outcome tracking. So that essentially the standard practice of medicine can be done remotely. Digital health is the overarching concept that you're prioritizing your virtual care, but connecting patients with a physical setting when it's appropriate. And we'll talk about a little bit more now about kind of digital health and those 3 main components. So the first is data. So it's been estimated that the average person will generate more than 1 million gigabytes of data in their lifetime. That's equivalent to 300 million books. So this includes blood pressure results, laboratory data, diagnostics, genetic testing, monitor data, and so it's really quite vast. And I think everyone can relate to that experience of having a patient come into the office with a stack of records. It can be quite time consuming to go through those records of a patient in a methodical way and pull out that useful data. You really need the digital means to synthesize it and the capacity to interpret it. And that's what digital health really does. Ultimately, it minimizes redundancy in testing, it improves shared decision-making between the patient and provider, and it changes management. Moving on, the sort of next component of the landscape is remote patient monitoring. This has really kind of exploded over the last several years, both on the clinical and the consumer side. So examples depicted on the here are a couple on the clinical side. So the Zio patient heart monitor, which allows for remote rhythm monitoring, the Butterfly Echo, which is depicted centrally, which is a handheld echo device which plugs into your iPad or your iPhone. And then on the consumer side, you have the Apple Watch, as well as the on-run blood pressure cuff as examples. Patients have really taken ownership over their health and become super users of these monitoring devices, and they need provider input as to how to interpret the data. So there's the demand, and there's really the need now to integrate and supplement our decision-making with these remote patient monitoring devices. And then the third, outcome tracking. So outcome tracking is following data longitudinally so that we can evaluate cost savings and outcomes. This is really best done digitally so that you can harness that computing capacity and analyze it and display it. You can't do it in the traditional episodic way. And ultimately, this shows evidence-based value. So I'll use this quote from Heartbeat Health CEO, Dr. Jeffrey Wessler, from an opinion piece several years ago. And I'll quote, "Imagine if Apple and Google followed a similar pathway, choose a high-risk population to test their devices, run a randomized controlled clinical trial, and provide a clear pathway to link the neediest patients to the right care. The outcomes could be spectacular, and if they aren't, we will know very quickly and move to the next idea." This quote speaks to this. So think about the sheer numbers. So you take an example such as the Framingham study, one of the most widely quoted cardiovascular studies that we've had, which initiated in 1948 and enrolled about 14,000 patients over the span of generations. You compare that to what Apple did back in 2015, which was initiate studies via their, such as a heart health study via their research kit, an app, and they enrolled 11,000 patients within the first 24 hours. So it's pretty remarkable. So 11,000 within the 24 hours compared to just about the same number over decades. Really, we need digital health to push our evidence-based practices to the next level. We're already starting to see some good outcomes data within this realm. So this is a paper just out of JAC this past month looking at 40 centers out of China. They looked at about 1,600 patients, average age was about 67, and they were trying to evaluate the benefit of a mobile health platform as part of care for atrial fibrillation. What they found was when you are looking at time to rehospitalization as well as time to composite outcomes on the right of ischemic stroke, thromboembolism, death, and rehospitalization, you're seeing improved outcomes on both sides. And so what this shows us and what I expect to see is that with the expanding remote patient monitoring landscape, the expanding virtual market, that we're only going to start to see more outcomes data on the benefit to those platforms. So where does cardiology fit into this landscape? Cardiology has been very slow to adopt telemedicine, partly likely due to reimbursement structure. It's always been advantageous for patients to come in the office, but it's here now. And what I would like everyone, or I would encourage everyone to do is read this article from the ACC from Drs. Ami Bhatt, Andrew Freeman, and Brendan Mullen, going through the nuts and bolts and the changes in CMS structure. as it pertains to telemedicine. So I will spend a few minutes talking about this. And the first topic is liability. The main thing to know about liability is that it is important to review your malpractice carrier to ensure that the carrier covers for remote visits. The second, in terms of locale, a telehealth service is based on the physical location of the patient, not the provider. So if you're at a state line border, if they are across state, this may mean licensing in multiple states. This has been blurred due to the pandemic. The Uniform Emergency Volunteer Health Practitioner Act has made it very, I would say, easier to practice in other states and expedite the licensing process. Documentation, it's the same as a face-to-face visit, but there should be a statement that that the services were provided through a telehealth means. And then billing. So we'll talk a little bit more about billing now. Medicare was really kind of ahead of the curve in terms of allowing beneficiaries access to telehealth services. In 2019, Medicare began paying for brief communications and virtual check-ins, and now reimburse telehealth as if they were face-to-face. So I think it's important to kind of to go over this. And what CMS does is they divide telemedicine services into 3 different categories. So you have the telehealth visit, you have the virtual check-in, and you have the e-visit. So a telehealth visit is what you would envision as your traditional telemedicine visit. So it's using both audio and video, and it's done in a synchronous way. So patient is talking to provider via video call, sort of like you're seeing right now. This can be any provider, so it's not just limited to doctors or nurses or nurse practitioners. It also extends to physician's assistants, to dietitians, case managers, and so this is all sort of all inclusive of providers across the field. Also important to note is that this can be both new and established patients. The 1135 waiver as part of the emergency declaration has allowed providers to see both new and established patients as opposed to prior to a recent history where it was only just established patients. So it includes, again, both new and established patients. Your virtual check-in, an example of this would be a phone call, 5 to 10 minute discussion between a patient and provider. So again, done in a synchronous manner and just for established patients alone. And then there's your e-visit. An example of this would be a non-face-to-face visit, such as a message that a patient sends through a portal. So it's patient initiated, non-face-to-face, asynchronous, and this is only for established patients as well. Also important to note is that the level of service for telehealth visits per Medicare can be chosen based on either medical decision-making or the total time spent on the visit, the day of service. And so below you see the billing structure and, again, both new and established patients. So that's important. So it's both medical decision-making or total time spent on the visit. This is the additional thing I would note is that all the components of physical exam are not necessarily needed if the complexity or the time meet a level 5 visit. Commercial insurances, many have followed suit, have been slower to adopt, but following, and it varies from payer to payer, so it's a bit more complex. This is a fluid situation. It's quite likely that this will change in the coming months, but as of today, these are the guidelines. So we'll go through some practical points. So choose your patients. As you get more comfortable with telemedicine, you'll get more comfortable with the types of patients that you can see via a telemedicine or telehealth platform. Abstracting, so utilize your support staff to reach out to patients. Utilize them to troubleshoot. Make sure your patients know how to use the platform prior to the encounter taking place. And know that it's a learning curve. So the first few visits, you may be viewing the ceiling or someone's nose, but ultimately it gets easier. Patients, providers get more used to it, and it does get better. Try to mirror your in-office structure as much as possible. So your standard visit, you walk in, meet the patient, start discussing history and what comes next. So don't let the fact that it's a different setting or a virtual setting interrupt that rhythm that you've been having for several years in practice. And then get creative. So for instance, have a patient push on their legs and show you whether or not they're edematous. Take advantage of at-home monitoring or remote monitoring. So if a patient has an at-home blood pressure cuff or a heart rate pulse oximeter at home, you can use this for vital signs at home. And then finally, if you're a provider who likes to review primary data with the patient, as I like to do, if the platform allows you to do so, you can share your screen to review that data, which is nice and patients find quite satisfying as well. So you're not necessarily limited from that capacity. So just a comment, so I'm currently serving as medical director of Heartbeat Health, which is a virtual cardiovascular care platform. They've been doing this for several years. Our telemedicine platform is simple, it's mobile based, it's as simple as downloading the app and talking to the patient. And we found that simple has worked quite well, and both patients and providers have had a positive user experience with this. I would urge everyone to also stay tuned as we're announcing an exciting partnership over the upcoming weeks, which should give cardiologists across the country all the ability to use the app. So in summary, care as usual is a thing of the past. As cardiologists, we need to embrace telemedicine. The world of digital health, data, remote patient monitoring, and outcomes tracking falls squarely into what we do as cardiologists. It really has kind of found a good place within our specialty. Establish a workflow. Know that it's a learning curve. Know that eventually telemedicine will mirror and probably enrich your practice in some positive ways. And know that digital health is the new healthcare. So the world of virtual health, this telemedicine, data, remote patient monitoring, and outcomes tracking, and its interaction with the physical world of medicine that we know and love will move the needle in terms of care delivery, evidence-based practice. So here are some additional resources on telemedicine and cardiovascular practice. If you have any questions for me, please email me directly or CVI's Executive Director, Mark Hartnett, at the email address listed, and questions will be sent to me. Feel free to share this link with anyone who might be interested on the information. And please let us know if there are other topics that might be of interest to you. Thank you for watching this CVI Heartbites segment. For more information on other CVI Heartbites segments, as well as other CVI educational programs, please visit us at cviphiladelphia.org or follow us on Twitter. Thank you.